We're going to get going and get started this morning in the CAM building. Thank you, everybody, for joining the Grand Rounds today, those who are here in person and everybody joining us on Zoom. My name is Olya Marcinch-Kolores. I'm a pediatric nephrologist here, and I am here to welcome you on behalf of our Department of Pediatrics and Dr. Mary Leonard, our chair, who's unable to join us today. So today we will be hearing from Dr. Amanda Williams on maternal morbidity and mortality through an equity lens from crisis to solutions. We'll have a bit of a formal introduction later. First, I'll bring your attention to some upcoming grant rounds. On February 27th, we'll have Dr. Colin Orr from University of North Carolina talk to us about Living the Dream, Reflections on Equity in Pediatrics. And then on March 5th, we will have our always very exciting residence housewide debate. And this year on, should we shorten 3-year pediatric fellowships to 2 years? Again, on the left, you can see the numbers to text to for your attendance today and getting credit. And then you could, if you fill out evaluation and answer a few questions, you could get MOC Part 2 credit as well. As always, we want to acknowledge that Stanford sits on the ancestral land of the Muekma Ohlone tribe. And then another reminder about our program, Pediatrics Internship Program at Stanford, short of it, PIPS. Right now, we are calling for mentors. This is a 6-week summer research internship for underrepresented in medicine Bay Area high school students. And if you're interested to mentor these students, please let us know at the contact information in the left lower corner. And today's lecture is on maternal morbidity and mortality through an equity lens from crisis to solution by Dr. Williams. This session will explore national and state trends in maternal morbidity and mortality, the etiologies, the contribution of race-based inequitable treatment, work of the California Maternal Quality Care Collaborative, that is what they are doing to address the maternal health outcome disparities and how technology can be leveraged to improve maternal health equity. And to introduce Dr. Williams, I will introduce Dr. Sonia Bonifacio, who is the professor of pediatrics in our neonatal ICU.
Good morning, everyone. I've reached the age where I need the reading glasses. So you're all blurry to me, but this is not, so that's important. So it's a great pleasure to be here this morning. I am Sonia Bonifacio. I'm a clinical professor in neonatology. I'm our faculty director of DIJ Strategic Initiatives, and I'm also the leader of our Healthcare Equity Task Force in neonatology. So it's a great pleasure to be here today to introduce Dr. Amanda Williams. She is the medical director at Mommy, a maternal health care company dedicated to improving health equity and empowering all families with wraparound care during the pregnancy and postpartum period. In this role, she oversees the company's clinical programming to better support mothers and birthing people while fostering institutional partnerships with academic medical centers, health systems, and payers. She also acts as the clinical innovation advisor to the CMQCC and serves as an adjunct faculty member in the Department of OB-GYN here at Stanford. Before joining Mommy, Dr. Williams worked at Kaiser Permanente, Oakland, where she served as the Director of Maternity Services. She also oversaw the maternity continuum for the chiefs of OB-GYN across 15 Kaiser medical centers in Northern California. She served on several state and national committees, such as the California Pregnancy Associated Mortality Review Committee and the National Quality Forum Maternal Morbidity and Mortality Work Group. She is a graduate magna cum laude of Harvard University in Cambridge, Massachusetts, where she majored in American medical history and biochemistry. She completed her medical training at Emory University in Atlanta, and she also received a master's degree in public health. She then completed her residency in OB-GYN at UCSF. So it's a great pleasure to introduce her this morning and have her give us our grand rounds for today. Welcome, Dr. Williams.
Thank you so much, Dr. Bonifacio. And thanks to all of you in pediatrics for having me. I spent my whole life in OB, and eventually there's a baby that comes out on the other side. So this really is all of our business to try to figure out this maternal mortality crisis. But 2023 was sort of the year of lots of awareness, which was with much doom and gloom. But now we really need to talk about solutions. We need to talk about what can be done differently, and that's what I'm here to do. So a quick pause on language. So you will hear me say maternal mortality crisis. Sometimes I will say birthing people. The key is that we want to hold space for anyone who has the pregnancy and postpartum experience and know that this applies to them as well. Also, she said in my introduction that I am the medical director of MOMI, and the concept there is that we are filling in the gaps of traditional prenatal and postpartum care. We know that way too often, a pregnant patient is like, those holiday bonbons that are like in the fancy tin foil, and as soon as the bonbon gets opened, the bonbon's like, oh, so beautiful. And then the wrapper gets thrown on the floor and the folks have the chocolate. And so our concept is that moms and pregnant people are more than the wrapper to the chocolate, that they deserve to be cared for. And that means lactation consultants, doulas, mental health coaching, et cetera. And that's what we aim to do at MOMI. And then I also advise a obstetrics alert and decision software that aims to take some of the bias out of decision making. The long story short is that maternal health equity is my jam. That's what I do. And I like to take all of the different pieces of my training and put it together to do this work. So what's the problem that we're trying to solve? And in honor of Black History Month, though I hope that equity work is part of what you do in Stanford Pediatrics all of the time, I like this quote from Dr. King, because truly healthcare is not a place where we should be seeing such inequity, yet we do. This quote also reminds me that doctors and nurses are good people. I am proud to be a physician. Most doctors and nurses have truly the best of intention, but there's a very significant intent impact gap that is sometimes a vast cavern for people. So to get beyond our, oh my God, is she calling me a racist? Like, no, she is not. But we live in a society that has inequities embedded in it, and we must deal with it. We must call it what it is and address it in all of us. So unless you've been under a rock, you know that we have a maternal health crisis in this country. And it's not just, this doesn't really work there. Oh, well, that is J. Marion Sims. And J. Marion Sims enslaved many Black women and used them for his experimentation. So J. Marion Sims is called the father of gynecology, the proud champion of gynecology. And as he enslaved Lucy, Betsy, and Arca and did scores of surgeries on them without their consent, without anesthesia. And as you can see, the other women looking on in fear, and then the other medical students and residents watching what he's doing. This isn't just because I'm a history of medicine nerd, which I am, but it's that obstetrics in particular, really all of American medicine, but obstetrics in particular is so deeply enmeshed with systemic racism that we have a huge body of work to undo this. This is not going to happen overnight, but it's going to take all of us making an effort to do it. So this public awareness really got started in 2017, 2018, when Nina Martin did the Lost Mother series in ProPublica. But 2017, 18, 19, and then Serena Williams came out with her story. There was starting to be a little bit of a groundswell, but it was a lot of preaching to the choir, a lot of Amanda as Charlie Brown teacher, like there's a problem, but not really being heard. But over the last couple of years, as COVID has shown us what kind of inequities are going on in American medicine, as we've had George Floyd, Breonna Taylor, had some of this waking up to the suffering in this country, there's been more attention to maternal health outcome disparities. And so this is an article that was in the New York Times that it's all research that's coming out of here, us at Stanford. It's a partnership between CMQCC and the economics department that took tax records and maternal death records and matched them to look for both newborn and maternal deaths. So at the highest tax bracket, the one that, you know, Serena Williams hangs out in, the maternal death rates were still double that for Black women. And the newborn death rates were double that of Black women compared to their white peers. So we can't explain with access. We can't explain with resources. So there must be more to the story. Now I'm flipping to the nation, and what we see here are the maternal mortality ratio. So that is maternal deaths per 100,000 live births. And to give you a sense of context, in Sweden, that number is about 5. Now, if you look here for Black birthing people in 2021, which is the last year we have complete data, it's about 70. That is not okay. What is going on? This is unacceptable. I mean, overall in the United States, it's not okay. How can it be 5 to 7 in most of Western Europe and it's 33 in the United States? What are we doing wrong? And then to have this level of disparity. Now, I want to point out that we can't forget that Indigenous people and Alaska Natives have maternal death rates that are very similar to that of Black birthing people. The numbers are so small, and it's not consistently that information is not consistently gathered across the country. That's why it's not in these graphics, but we don't want to forget about that population also. Now we're here in California. Sometimes we forget how big California is. 1 out of every 8 babies in this country are born in California. Now, the cool part is what we do at the California Maternal Quality Care Collaborative, the Perinatal Care Collaborative, if we can move it in California, we may be able to move for the entire country, and we can really make a dent in this work. We're also an incredibly diverse state. So we can't have this kind of disparities when this is really what our population looks like. And we're super proud that with all the work that's gone on with CMQCC and CPQCC, we are in California doing way better than the rest of the country. So this is the maternal death rate. This pointer is not my friend. This is the maternal death rate up through 2008. And you'll see that California was essentially the same as the rest of the country. But then you'll see this huge divide that happens, and California starts diverging. And that is very much a credit to our colleagues here at CMQCC and CPQCC, and that divide has remained. Now, this slide's a little misleading because everyone in 2019 through 2021 has gone up, but they don't cross. They still stay parallel. California still does stay ahead of the rest of the country. But we have to have these sorts of rates for all of our populations, not just for the entirety of the population. So let's go through a little bit. What do we know about maternal death? And this next set of slides is a combination. It is the California Department of Public Health in partnership with CMQCC. So when are people dying? Back to my comment about why mommy is working so hard to take care of patients in the postpartum period. So our top causes of maternal death: cardiovascular disease, hemorrhage, infection, hypertensive disorders of pregnancy, thromboembolic disease, and amniotic fluid embolism. You can see there's a huge burden of disease that's happening postpartum. So in that dump the candy wrapper period, we really need to be paying attention to patients, but we're not. And that, again, is a huge role for the pediatricians, because new moms all the time will neglect themselves in favor of their baby, but they will find a way very often to get to those pediatrics appointments. So having remote patient monitoring, having ways of filling in those gaps and partnering with pediatrics is incredibly important. We can see here that we have some changing demographics around when the reasons that people are dying over time. Now, this decrease here in hypertensive disorders of pregnancy, this is very much a part of the quality improvement work that's come out of CMQCC and spread around the state of California. When we're having systematic approaches to common obstetric complications, when we're learning best practices from other hospitals, there's a huge benefit that can happen. And it's that working in conjunction, working together, sharing a little bit of data at the hospital's discretion, that it really does make a huge difference. Now, of course, COVID showed up at the end of this time period that changed the maternal death dynamics. And we know that COVID goes both when you have COVID in a mother, the pediatric outcomes are worse and the maternal outcomes are worse. And when someone is pregnant, they are more, their COVID is going to be worse. So it works back and forth. So getting pregnant patients vaccinated for COVID is incredibly important. We also know that there is a huge impact of age. So we have to know who are our patients who are the most likely to have a poor outcome. It doesn't mean that it's inevitable that it's going to happen, but we have to know what that increased risk looks like. And then same concept by BMI. So age, BMI, this is not about patient blaming, it's about appropriate risk assessment. So that when you are, let's say, the OB anesthesiologist on labor and delivery, you have to constantly be thinking of who are my patients that are the most likely to have a poor pregnancy outcome. And then payer type. So everyone likes to say, I treat all of my patients the same. That is definitely not necessarily the case. And there are huge access issues that are woven in there. We have to keep remembering that 45% of the births approximately in the state of California are insured through Medi-Cal. We have to have good programming in place for our pregnant patients who get their care through Medi-Cal. And then community matters. So we'll talk a little bit later about social determinants of health or health-related social needs. Regardless of the naming convention that you use, we know that neighborhoods, that community conditions play a role in maternal mortality as well. And then this is my go-to slide. This is the slide that, let's be honest, got me my job. It's the slide that gets me up in the morning, is to do something about this. So in California, we have these incredible collaboratives in pediatrics, in OB. We have hospitals working together. We're addressing common complications like sepsis, like hypertension, like obstetric hemorrhage. cardiovascular disease, COVID. We've run all of these collaboratives, and we have the lowest maternal death rate in the country when you take the entirety of the population. These are all things to be super proud of. But unless those benefits are shared by all, we cannot rest. We still have significant work to do. And a lot of this decrease here in the ratio in these two time periods is because of that hypertensive work. We have, whenever you do standardized care, whenever you are running doing that kind of quality work, there are going to be disparities benefits that come from it. But what we're left with here is really the need to address equity and think about how systemic racism has found its way into care. And then I think this is my last, data slide. This shows the different causes of death by race, ethnicity. So the thing that always gets me on this slide is this little number right here. The scale here is 1 to 3. There's so much maternal death in Black birthing people, it can't fit on the slide. Like, that hurts me to my soul. Like, this is why this work is so incredibly compelling. And you'll see the numbers here. So this number is 14 compared to 2 or 4. So it would take this whole slide with just cardiovascular disease. So we have a real situation here that needs desperately our attention. So I know that there's in the Department of Pediatrics, you guys have been doing quite a bit of equity work. I will not belabor the point, but just to call everyone in as allies. If you hear somebody say, I treat all of my patients the same, I want to treat everyone the same, that is a stop and think moment. And I call on all of you to hold each other accountable. And say, like, hey, you know what? There's been a lot of thinking done about treating everyone the same, and that's actually doing harm. It's not intended to do harm, but if we treat everyone the same, we are going to have the same disparate outcomes. Unless we give people what they need to be successful, they're going to continue to struggle. So I really appreciate this Robert Wood Johnson Foundation image of the bicycles, because we all need something a little bit different to have the goal that we want. And the equality piece that we want is equality of outcomes. But equity is all about the process to get to those outcomes. For folks who are newer to this work, I would commend to your reading. It's quite dated now. It was one of the original pieces, Dr. Kamara Jones and The Gardener's Tale, one of the pivotal pieces of sort of health equity theory. But the idea is that it's about inherited disadvantage. We see in low-income communities, low-opportunity communities, heart disease, obesity, asthma, diabetes. It's not about something that folks are doing wrong or about a certain genetic polymorphism. It's about all of these other pieces of the puzzle that have then led to a combination of inequity in terms of treatment, in terms of opportunity, and then some epigenetics as well. Now, when I was at Kaiser in the Permanente Medical Group, I had the privilege of leading the health equity work in women's health. And I think as you think about, like, okay, so what are we gonna do? What are we gonna do? How are we gonna put projects together? Like, sometimes when you think about this, you get that overwhelming sense of it's been 400 years of enslavement, of Jim Crow, of housing segregation, of mortgage practices, of educational practices. Like, how are we going to do this? And that's when we need to, take hold of ourselves and say, okay, we have to think about this systematically. We have to have a vision. We have to set goals. We have to put a framework together so that we can do things like measure. We got to go back to the data. We have to think about what are the barriers. We need to engage our patients and our clinicians and staff. We need to have a systematic approach to addressing these sorts of overwhelming type challenges. Now, I think most people here know what CMQCC is, so I'm going to go fast. But CMQCC is the California Maternal Quality Care Collaborative. We're housed here at Stanford. The mission is to end preventable morbidity, mortality, which, though not ended, has made tremendous strides, and racial disparities in California. And that is where there's still a lot of work to be done, but we are really doing it. The way that this works, and I'll be honest, when I was at Kaiser, which is a member hospital of CMQCC, I had no idea that other states don't have a maternal data center. Like, that's just, it's always been that way in my career, almost. But this is incredibly unique. So what it takes is discharge diagnoses from all of the hospitals, and there are 219, essentially every hospital that has a maternity unit in the state of California gives discharge diagnoses. And then there are the chart reviews that are coming from the nurse management, quality staff, and then matched with vital records like birth and death certificates. And it all comes together into the data center. And then we package it, make it pretty, make it searchable, make it filterable, so that you can then design QI work inside of your hospital to address these issues and be part of collaboratives across the state to have these systematic responses to obstetric and pediatric emergencies. So it is really extraordinary. So we take the maternal data center and we have the collaboratives, we have toolkits, we have workflows. I was actually volunteering at a hospital in central Tanzania, and I looked up on the wall and there was the CMQCC hemorrhage management guide on the wall, like in the middle of Tanzania, and I just lit up. It was awesome. Actually, what I did was take it off the wall and rewrote it with materials that they actually had there because they didn't have all the things in the algorithm. But anyway, it's had an incredible impact around the country, and particularly here in California. And this is what it looks like. So instead of just having the numbers, you can actually do run charts, you can stratify by different payer types, you can stratify by race, you can stratify by language, and then there's all kinds of measure analysis. Like if you're looking at your C-sections, are your C-sections mostly spontaneous labor versus induced labor? There are all these tools in there to help hospitals be better, and that really is something to be proud of. Now, we do this for maternal deaths, but we're also looking at common things. So C-sections happen every day. So this is an everyday occurrence. And yet, even when we adjust for different medical conditions, we see tremendous racial difference with C-sections across California. We similarly see it with severe maternal morbidity. Now, severe maternal morbidity is the severe complications of pregnancy, things like sepsis, things like OR takebacks, like ICU admissions, eclamptic seizures. Maternal mortality is rare. So I came out of residency in 2005. I have seen 6 maternal deaths, either directly or tangentially, in my entire career. Can you do a lot of research with 6? No. You can learn, but it's so rare that you need huge populations for longer periods of time. Severe maternal morbidity, you see on Stanford Labor and Delivery once a week, or at Kaiser Oakland, it's certainly every week or two. So we can really learn a lot from these near misses about what's going on in terms of race, ethnicity. And for Black and Indigenous birthing people, you can see here and here, we have significantly increased rates compared to their white counterparts. So what are we doing at CMQCC? So we're really thinking about what projects are we going to be supporting? And are our projects going to be taking a bite out of this issue? So we're choosing initiatives that can potentially disproportionately benefit communities that have been marginalized. And we're doing it with attention to community and with attention to these disparities. So as you can see, there's lots of work around anemia, hemorrhage, doulas, midwives, preeclampsia, our low-dose aspirin campaign in partnership with the March of Dimes, the Pregnancy-Associated Mortality Review Committee, sepsis. We're partnering with the state of California and Department of Public Health on redesigning postpartum care. We have the privilege of really being at the table with CDPH and DHCS to really try to make things different. And so that's one approach, is to weave equity into the projects that have a clinical focus to make sure you're constantly segmenting your data and getting community engagement from the folks who are impacted most. Then we have a body of work that is equity specific. So between 2018 to 2020-ish, even though they keep wanting to keep meeting, we had the pilot birth equity initiative. And that's where we started thinking about what tools do hospitals need to do this work intentionally. We in California have the benefit of requiring implicit bias training for all perinatal providers. Now, there are many, many states. The vast majority of states do not have this. We think this is the floor. This is to find common language. That is where we start, is with some basic implicit bias training. But there's so much more that has to be done. That can just be a clicky box. That can just be something that someone taps through, like some of our other, HIPAA training for the year, our EMTALA training while you're making dinner. I don't want that to be all you have of equity, is implicit bias training. We need to put it to work. So what does that mean? How do we instill accountability? How do we really use data to drive change? And in particular, think about culture and the role of culture on our units. So we have this culture of equity survey that we've developed that will hopefully be a big part of this work and help us address microaggressions. Now, microaggressions, I'm sure you guys have heard lots of stories of microaggressions, but boy, they are real. And it's that, death by 1,000 tiny pitchforks kind of concept, right? So it was about 6 months ago now, was taking a labor and delivery shift. And it's really different when you used to be the boss and now you can just show up and work a shift and leave. But I came onto the unit and there was a new assistant nurse manager, and I was talking to my colleague who was the outgoing night doc, and she came up and she looked at him and said, "Oh, good morning, Dr. So-and-so," and then looked at me and said, "Oh, hey, Amanda." And I was like, "Oh, this is interesting." you know, there are lots of nurses who call me by my first name, but it's because we know each other, because we have shared history. This is a woman I have never met before in my life. And she comes up to the colleague, and here we are, peers, even though not really. He's like 15 minutes out of residency, and I had hired him 2 years ago. But anyway, and we're doing our handoff, and I just was stunned. So I carried on, we did our handoff, and then I went back to her and I said, you know, I don't know if you noticed, but when you came on and you greeted Dr. So-and-so and me, you said, referred to him as Dr. So-and-so and referred to me as Amanda, and you don't know me at all. And there I was, white coat, badge, stethoscope, all the decorations of medical identity. And I was the chief for 10 years and had hired this guy. And I said, do you think it was because I'm a woman or because I'm Black? And she was like, oh, no, that must be a mistake. That must be a mistake. I never call doctors by their first name. And I said, oh man, that's worse. Because that means you didn't even see me as a doctor when I was standing there in front of you. So you can be 20 years out of residency and still be having this experience. So this is the real life of your colleagues. And so when we think about the mental shortcuts that our brains take, and we do it to our colleagues, it teaches a lot about how we treat patients. So what are we doing now at CMQCC? So this is our new-ish CDC-funded 5-year grant to look at supporting vaginal birth with an equity lens. So we did tremendous supporting vaginal birth work across the state of California. Low-risk C-section rates have very much come down, but as I showed you, there's still significant disparities in C-section rates. It's not all Black birthing people as the outlier group. In many areas, it's the Spanish language speaking patients, it's the Asian patients, which is really difficult because it's so heterogeneous. So you've got to know your population. But what we've done is looked for outlier populations in each hospital and found which are the hospitals around the state of California who want to do this work and are engaged to address these disparities. So we have to touch everyone. That's our commitment to the CDC. But we are running, it's called the Learning Initiative, but it's basically this CMQCC style collaborative to bring the hospitals together and really walk with them through an 18-month performance improvement project to decrease those disparities. And then what did we use? What are we using to do this? We're using this hospital action guide for respectful and equity-centered obstetric care. So this is sort of similar to how CMQCC has toolkits of resources, learnings, et cetera. And I'm going to show it to you in a little bit more detail. But this is the curriculum, and it also can be used standalone in order to start doing equity work in hospitals. Now, if anyone can come up with like a shortened version of this, a cool acronym, because it's really long, but the words were important to us. At first, we called it the HAG, but like the feminist in me could not let it be called the HAG. But we need some way to make it shorter. Anyway, this is the new equity tool. This is available to every person in this room, every person who has a Stanford email. So anyone in a hospital system that has a labor and delivery unit in the state of California has access to this. So this is the Hospital Action Guide for Respectful and Equity-Centered Obstetric Care. You can get to it through the cmqcc.org website. And it is full of tools and actions that a unit can take or a group can take to start doing equity work. So these are the different modules. This is what you see when you come onto the Action Guide landing page. And then the different modules are aligned here. One of them, my favorites, is creating a culture of respectful care. So if that's something that you want to do on your unit or in your division, there are learning opportunities, and then there are action steps. This is not just about a reading list or a resource list. It really has actions that can be taken on your unit. And then lots of resources, case studies, et cetera, for us to use also. So for example, urine toxicology screening. Who are you ordering UTOXs on in the NICU? Let's think about how that might be impacting certain populations. What does the art look like on your unit? Do your patients see themselves in that art? There are lots of actions that can be taken using this guide. Right, and then, so we're running the collaborative, we have the guide, and then we have a webinar series that's happening quarterly. The next one is tomorrow at noon. But for folks who kind of want to do the Cliff Notes version, if you will, the webinars are a good way to do that. And then also we use it for engagement, and we have the webinars that are open to the public as well. And then we have office hours to support the hospitals doing this work too. We recently expanded our work with an NIH grant that came through the OBGYN department and the Maternal Health Research Center of Excellence that we have here at Stanford to look at preventing inequities in hemorrhage-related severe maternal morbidity. Now, I was on the hemorrhage subcommittee of the Pregnancy-Associated Mortality Review Committee for the state of California. And I will tell you that this was a life-changing experience for me. To be that deep in the charts, the notes, the labs, the op records, the nursing communications of these moms that died was jarring. We know nationally that 80% approximately of maternal deaths are preventable. In California, we should be super proud that that number is 60. But that's still not awesome, that the majority of the deaths are preventable. And so as I'm sitting here steeped in this work, I just kept thinking like, oh my God, that could be my sister. That is me. Like, where, but for the grace of God, go I. I had severe maternal morbidity. I would have been on that chart when I had my severe preeclampsia in 2004 and my baby in the NICU. You know, this is real. This is a body of work that deserves our study, our time, and attention. So through the PRISM work, so that is a 7-year NIH study, we are going to be assessing some of what we're doing with the Hospital Action Guide and also in our learning initiative. So we are about 9 months in of our first cohort of hospitals. We just sent out recruitment letters for the next cohort of hospitals, and we're going to be trying to figure out which of all of our tools is the most impactful. And then how are we promoting use of the Hospital Action Guide around the state, and how is it being used? Because if we don't study it, we don't know. And so we've got to be able to have the research behind it so that this kind of work can be spread across the country. And we're grateful to be able to have both the CDC and NIH funding to do it. Last piece of the puzzle is technology. And let me give myself a time check, 43. Okay, good. So anytime you see a digital landscape that's this crowded, you're like, oh, there must be a problem. Like, people are trying to solve a problem. And there are a lot of players in this digital women's health space. And in my neck of the woods here in pregnancy, postpartum parenthood support, even there are quite a lot of companies. So I know mine is certainly not the only one. And I am an abundance mindset person. I do not see these as my competitors. This is the group of people who are in this work with me, and we need collaboration in order for it to truly move forward. So where do I think that technology can most play a role? Remote patient monitoring is certainly one of them. I don't know how many of you have been a new parent, but leaving your house when you have a 1-week-old baby is like scaling Mount Etna. It is such an incredible undertaking. And to think that you're going to do that for your baby and to come back in for a blood pressure check? No, not going to happen. And unfortunately, with things like hypertensive disorders, patients often feel nothing until they're near having a stroke. So especially for patients who are at increased risk, patients who've had issues during their pregnancy, getting those blood pressure cuffs, getting remote patient monitoring in place can make a tremendous, tremendous difference. Also with glucose monitoring during pregnancy, another super important option for patients, having Bluetooth or LTE enabled glucose monitors make a huge difference. With preterm labor, it's a little bit different. It's not so much about, there were some, especially in the 90s, thought that we could have these remote contraction monitors and put women on bed rest at home with remote contraction monitors. That really didn't pan out. So much is about symptoms, and about the patient's report is actually even more important. But who's checking in? So whether it's psychosocial or whether it's preterm labor symptoms, who is checking in on a regular basis between clinical touch points? I think sometimes as clinicians, we forget that patients have a life outside of the doctor's office. They're actually out in community, living their lives, taking care of their older kids, doing their jobs. And so who are they going to go to? Are they going to call the call center where they're going to be on hold for 10 minutes and then maybe talk to someone who doesn't really know them? So having these psychosocial and symptom management check-ins is a really powerful option. Then wraparound services. I don't think there's anyone in here who would argue that these pieces of the puzzle are important in pregnancy and postpartum care, yet they are almost never integrated into care. People are off doing it one place. Okay, you're going to go over here to see the lactation consultant, and where are you going to go and get mental health support? And oh my gosh, it's a 3-month wait for someone who has peripartum depression. Like there's such a lack of coordination. So I think there's tremendous opportunity in terms of getting this care accessible to folks, not just a referral that you put on a piece of paper that's sometimes no better than a high five. You want to actually make sure that patients can get to the care, whether it's in person or virtual. And then the care navigation piece of it, the social determinants of health, health-related social needs, those types of things, someone's transportation, their housing, their nutrition. If those things aren't being attended to, it doesn't matter if you got them an appointment, if they can't get there, if they don't have their basic needs met, then they're not going to be able to take advantage of those referrals. So what do I think is going to happen in 2024? I think that we're going to see a lot of consolidation and integration into more systematic care. So that we'll see partnerships with payers, partnerships with hospitals, in order to start bringing some of this care into the traditional medical model. The Joint Commission and CMS have both come down on social determinants of health social drivers of health, health-related social needs. People have different phrases that they use, but what we're talking about is those pieces of the puzzle that create the community for people to either have healthier or less healthy lives. There has to be more attention, and CMS and Joint Commission pushing for it should start making a difference. I wish people would do it just because it's the right thing to do, but sometimes when their pocketbook is attached, all of a sudden they're newly inspired to do what we know is the right thing. And then doula care expansion. So 12 states in the District of Columbia now have a Medicaid doula benefit so that patients who are insured by Medicaid can get doula care. Now that's awesome on paper, but there's a lot of operational nuance that's required, that has to be overcome in order to make this successful. There has to be a livable wage for the doulas. We need to do something about the administrative burden for doulas who want to sign up and be a part of it. And then also figure out how to get that awareness to patients around doula care. So if you're going to put together a maternal health equity strategy for your department, your division, your organization, I think there are lots of pieces of this puzzle that we've touched on today, that it's not going to be one thing. We're going to need to have this ongoing unconscious bias training. As I said, lots of states don't even require it. Lots of hospitals don't, but it's starting to be more and more. And as there are equity requirements from CMS and Joint Commission, I think that will help this piece of it. We need to think about recruitment strategies. Are we recruiting for our residencies and fellowships from the same medical schools and residency where we always go? Are you blinding your readers? Are you doing, are you having, oh my gosh, I'm having word finding difficulty. Are you getting a sense of who your potential residents are without looking at, oh, it's my friend from my training who wrote her letter? Are we thinking about what people's capacities are? Data performance improvement projects, every hospital must be segmenting their data. If you're looking at just the general trends, you are almost certainly leaving folks behind. As the phrase goes, unless you are intentionally including, you are unintentionally excluding. And so we have to really think about our data and then design projects that support this work. We, of course, need to leverage technology and think about where can we use remote patient monitoring, where can we use virtual services to help bridge those gaps. And then, of course, presentations, speakers, ways of thinking about this in different ways, and then getting in touch with community, because almost always the answer is in community. If you ask patients what it is that they need, oftentimes they have the answers. And you can't just have like, oh, we'll have a town hall at the medical center in the cafeteria. People don't want to come to the medical center. You're asking them to come to their turf. We need to go out to the community centers. We need to go to the churches. We need to have that kind of partnership that comes with that humility and saying, we want your voices at the table. So if one's trying to think about how do we put together a more comprehensive approach to health equity in our organization, these are some of the pieces of the puzzle that I would certainly recommend. All right, well, I think that is it for me. Hopefully you guys are excited about engaging in some of this work in the Department of Pediatrics. We're so grateful to have you as partners. As I was talking earlier, you know, pediatricians are probably much better listeners than OBs. OBs move too fast and they depend on their patients to be able to tell them what's going on. Pediatricians have to listen differently because a lot of their patients aren't particularly articulate. So you have to look for nonverbal cues. You have to look for what's the energy in the room. So help your OB colleagues along and really think about how do we listen deeply to families, especially those that are different from us. All right, I think I will end there.
Thank you. That was great. Really inspiring. We have a few questions in the chat, and I'm happy to pass around a microphone if anyone has any questions here. I'll start with what is in the chat. Has there been any discussion of addressing adverse childhood experiences in your approach?
Yes, very much so. And I am remiss for not bringing it up. One of the projects that I had the privilege of trying to get off the ground in Kaiser Permanente, Northern California, is integrating ACEs screening into prenatal care. And in fact, out of CMQCC, there's a Green Journal paper on how one might do that effectively. Because sort of the original ACE is, to some extent, the in utero environment. So I think that there's a lot of opportunity there, and whether it's through care coordinators or hopefully through traditional prenatal care, I think that there's a lot of opportunity.
Any questions in the audience? I have one here. Start here.
Got it.
That was one of the best presentations I've seen in a while. Thank you. One of your slides talked about third-party payers and reimbursement as being a driver of improvement. I guess you're an idealist as well. What gives you hope that or evidence that that's going to come from third-party payers?
So two things. One, we have an excellent example here in California. We know that maternal deaths, as I showed, are between 2 and 3x that for Medicaid patients compared to commercial insurance. And we're a part of a whole Medicaid, Medi-Cal redesign through DHCS in the state. So between the implementation of the doula benefit, the increased wage associated with doulas that just got passed this year, the passage of CalAIM, if you're familiar with that, and the community supports, as the Medi-Cal MCOs start picking up community supports, I think that we actually really can do this. One of the things that I'm really pushing for is 2-day dyad visits, and to really keep the mother-baby dyad together and seen together in the early postpartum period, and to reinvigorate home nursing, and also then leveraging technology to be able to do it. So this work is very actively going on in California and hoping to be, a model for the country.
One of the questions online was about dealing with like missing data, or in terms of race ethnicity data, and how is that dealt with in CMQCC? How do we deal with the category of others, and or other race, and how do we deal with multi-racial, multi-ethnic people?
It's so hard. And our communities are more and more mixed, more and more heterogeneous. And so, they're always going to be the lumpers and the splitters, right? So you can lump things together so you can study them better, or you can split them apart to have more, precision and integrity, but then you can't really design programs that way. So we are constantly trying to find a balance of those two things. So oftentimes we will do our analysis around top 5 demographics at a particular site, to be able to do the work. Also, we have very targeted outreach and methodology, including slide sets, talking points, for hospitals to help improve the sort of ticking of checkboxes on racial identity, and even to work with the clerks, the, what do you call them? Vital statistics clerks. Vital statistics clerks are really powerful people, because what goes in that record, that is so much comes out of there. So to work with your vital statistics clerks about how to ask the question, there's a lot of concern around immigration and people being afraid of disclosing identity. So it's very important to just speak into it and let people know what's the intent of being able to pick a particular racial box.
Go ahead.
Hi, thank you so much for this talk. It's been wonderful. I was really heartened in the last year how many states, I think we're up to 44 now, are covering postpartum women for 12 months.
47.
47, excellent, which is amazing to see our country do something so uniformly at this time when it comes to taking care of low-income women. So I've been very heartened by that, wondering how you think that might help move the needle in the right direction. And then the second thing is, in terms of for California and dyadic care, getting that same-day billing passed is the linchpin. And totally failed last year. We're going to try again this year, but to make that happen, that's the structural change we need. So interested in thinking about advocacy opportunities for that.
Absolutely. There are actually quite a lot of advocacy opportunities in this sort of perinatal period. Having that year benefit is like tremendous. It allows people, excuse me? So to have, instead of having your Medicaid just for 60 days postpartum, you have it for the entire year postpartum. So when you think back to that slide of when maternal deaths are happening, there are a lot of maternal deaths that are happening after that first 60 days. Additionally, that allows the handoffs for high-risk pregnancies, so people to get their diabetes screening, to get back into care, to lose pregnancy weight, to get their hypertension under control, to get their regular health screening. There's so much opportunity, and the main one is the handoffs that back to their PCPs, or if they need specialty care follow-up. So that is a tremendous way of supporting. And, you know, when you have a healthy mom, it tends to bubble over into the rest of the family, and those community supports that we were talking about as well, extending make a huge difference. In terms of policy advocacy, certainly doulas around the country is a big piece of policy that's worth sort of fighting for. Dyadic billing, as you said, is a big one. Letting pediatricians bill for maternal depression screening and referral is another huge one. We have, I could give a whole nother talk on maternal mental health crisis, which is very serious in this country, and pediatricians have a big role to play, yet unless they can bill for it, it's really hard to incentivize people to do that work. We also need to have folks to refer to in order to get that done. And then with mental health, the ability to do cross-state telehealth made a huge difference during the pandemic, and now it can't be done. With you know, college student in Michigan, it's very near and dear to my heart that we have to make sure that we can get people the care that they need. And one way of doing it is to be able to leverage places that have more providers. So lots of advocacy opportunities.
Great, thank you. I'm just gonna finish with this question. You started with talking about intent versus impact. And so how do we, in the moment, when we're going into a patient encounter, what are the possible ways where we can think about the impact of our actions in that moment in our decision making? What is it that you do personally when you go into a room and you really have to like focus on what is the impact of what I'm going to do versus what is the intent?
Oh, what a juicy, good question. So I think we need to learn from our sort of neuropsych colleagues. What are the cognitive tools that we can use to slow ourselves down and really be present? So I personally, every time I go into a room, I knock 3 times. And that is the trigger to my brain to say, no matter what else is going on, that there's someone hemorrhaging in the ED, you have 3 consults to go see, somebody's waiting for their C-section, like you have to be here now. And so I knock 3 times and I tell myself, be here now. And that is my way of telling my brain to slow down, don't do shortcuts, don't be looking for patterns, actually stay and listen. And then the other one, my partner taught me, does a lot of business negotiation, is listening for the last letter of the last word that the person says. So you have to be paying attention so much to their words to really think about what is the last letter of the last word. Because what we start doing as physicians in particular is doing the shortcuts. Okay, she says she's got swollen legs, she's got high blood pressure, preeclampsia. Okay, she's seeing some blood, she hasn't had her ultrasound yet. Okay, previa. Like we're always racing to make a diagnosis, to take those mental shortcuts, which can make us good clinicians, but it can really perpetuate bias. And so to use these sorts of cognitive tools to slow ourselves down and to listen harder, as I like to say, the more different someone is from you, the harder you need to listen. Because you don't have that, oh, that's my sister feeling. Oh, that's my cousin, where I'm going to give her the benefit of the doubt. I'm going to be a little bit more conservative. So to use our tools and then make sure that the patient feels heard, to ask back, like, hey, I know we went over a bunch of things. It's really important to me that we're on the same page. Can you tell me what you think I think is going on here? Or I think the next step is, or what kind of medication you might need. So to really do that teach back after you've deeply heard a patient. So thank you. Whoever asked that, thank you very much.
Thanks so much. So happy you're here today. Thank you.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.